Good morning. Welcome to the Injury Control Research Center webcast of our presentation entitled In the Pursuit of Innovative Treatments for Substance Use Disorders. Is Mindfulness an Answer? My name is Keith Zullig. I'm with the Department of Social Behavioral Sciences at the School of Public Health.
My name is Meghan Tuscano, and I'm a second-year MPH student at WVU for the School of Public Health.
And I'm Laura Lander, social work faculty in the Department of Behavioral Medicine and Psychiatry in the School of Medicine.
And we are all part of the main research team for our project. A couple acknowledgments. We are supported by the Centers for Disease Control and Prevention through our Injury Control Research Center for this research, and we do not have any conflicts of interest. We would also like to acknowledge other members of the research team, our therapist, Laurel Falconberry, who leads our individual mindfulness sessions for our intervention. And we also would like to acknowledge Dr. Jerry Hobbs, who provides us some statistical support for the project. Some of our learning objectives are to gain knowledge about the prevalence of substance use disorders and overdose rates nationally and in West Virginia, understand the disease model of addiction and how co-occurring mental illness can impact treatment efficacy. We'd like to learn about mindfulness-based relapse prevention, and finally, gain knowledge about new research using this intervention and outcomes of our recent study.
So just a little bit of background. It's certainly been in the media nationally and in West Virginia, the impact of the opioid epidemic on our citizens. So this is some information about drug overdose deaths. And one of the significant trends that we're seeing is the increase in synthetic opioids. So when we look at the number of overdose deaths, the vast majority of those, typically about 80%, are as a result of ingestion of opioids, and then most recently, the emergence of synthetic opioids, such as carfentanil and fentanyl, being responsible for more and more of those deaths. The other trend that we are seeing is cocaine and methamphetamine increases with regard to overdose deaths, and often these are mixtures. So not just methamphetamine alone, but methamphetamine mixed with synthetic opioids or other opioids that cause the overdose deaths. Specifically in West Virginia, we have led the nation since 2010 in the national overdose death rates, and in 2017 that trend persisted. We had over 1,000 overdose deaths in 2017, and some of those are still being counted. So it's not even the final result. So this is a 15% increase from 2016, despite the increase in awareness that this is happening. The state has made major adjustments to prescribing practices, and yet the deaths continue. So one of the things that we're trying to address with this study is how can we better develop treatments for individuals with opioid use disorder to better treat the disease so that we can reduce the overdose deaths in that way. Just wanted to do a brief overview of the disease concept of addiction. So this concept has been around for a long time. The disease model is really about identifying a defect, so a physical defect, which results in symptoms. The physical defect in the disease of addiction is in the brain, and the symptoms are often behavioral, psychological in nature. So when we think about addiction, it's a chronic disease, so it's not one that can be treated in 12 weeks or in a short course of treatment. This is treatment over a lifetime, and it's typically characterized by an inability to abstain from substances even if the person wants to, behavioral problems, craving, and craving has both physiological and psychological components, diminished recognition of problems, and sometimes people refer to that as denial. So in the face of significant problems, people still identify, oh, I don't really have a problem, I can stop when I want to. And then a dysfunctional emotional response, and that often emerges as psychiatric symptoms. These are the current kind of range of treatment options. So there's inpatient detoxification for substance use disorders, which is typically short-term. So as we said, it's a chronic disease, so detoxification is simply one small piece of treatment. There are residential treatment programs ranging in duration from 2 weeks to 6 months, and those are much harder to access for most people because there are not as many of those treatment programs around. There's outpatient therapy, and that can be intensive therapy 3 times a week or once a week, or even less often if people don't have as intense a need. And then specifically for opioid use disorders, there's medication-assisted treatment with methadone, buprenorphine, or naltrexone. There are also medication-assisted treatments for other disorders, such as alcohol use disorder, using Campril or Antabuse. Specifically, we're going to be more focused on talking about opioid use disorders today. One of the things that makes treatment more complicated is when someone has not only a single disorder, like an opioid use disorder, but has that in combination with an additional mental health disorder, such as anxiety, PTSD, or depression. And so you're treating 2 disorders at the same time. And so it makes sense, like with any disease, that if you have 2 disease processes going on at the same time, you need different kinds of treatments. And it's really theorized that one of the reasons that medication-assisted treatment or other behavioral treatments do not work for some people is because they really have 2 disorders. And our study specifically was trying to get at this issue of patients coming in and having 2 disorders, and how do you treat 2 disorders with a single treatment. The incidence is about, it depends on what year you look at, but anywhere from 4.6 million, and I've seen as high as 7 million American adults have both a substance use disorder and a mental health disorder. And among the population that I work with at Chestnut Ridge Center, it's really about 60 to 70% of the individuals coming in seeking treatment for their substance use disorder also have a co-occurring mental health disorder. So it's very high, higher than the national average. So the components of good treatment have these 3 parts. There's a biological component, and with medication-assisted treatment, that would be the medicine, addresses the biological component, which includes cravings and assistance with withdrawal. So people who suddenly stop using opioids, who are physically dependent on them, will have withdrawal, and so medications can help with that. And then there's a psychological component, and that's usually addressed with the psychotherapy, and that can be cognitive behavioral therapy, or what we used in our current study, which is Relapse, is mindfulness-based relapse prevention. And then the social component is usually community-based supports, such as 12-step groups, or any community-based recovery group, such as Smart Recovery or Celebrate Recovery. Other kinds of social supports are family therapy, and also spiritual community support. So if someone is a member of a church and is able to find support in that way. So trying to foster social connections is really part of what helps people become well. And to give a little bit of background about mindfulness-based relapse prevention and what it is. So the term mindfulness and being mindful has been thrown around a lot in recent years, and I like to simplify it simply to say that mindfulness is being in the present moment and being aware, so present moment awareness without judgment. And while that sounds simple, it can be very difficult to do in our lives where we have lots of things pulling on our attention and lots of electronic things pulling on our attention. Even trying not to, if you are physically awake, trying not to look at your phone for an entire hour can really be a challenge for people. But when we go to the phone, it really pulls us out of the present moment. It's practicing how to be in the now, and while that seems odd to have to practice, it's true. Many of us really are often thinking about the past or thinking about what we need to do in the future rather than being in the present moment. It's about increasing awareness of your physical self as well as your thoughts. So some of the interventions have to do with focusing on breathing, focusing on physical space, or focusing on what's happening inside your head. Increasing acceptance of sensations, thoughts, and feelings. So again, working on that suspending judgment, just being an observer, being curious, as opposed to rendering judgment on what you are doing or what you're thinking. Self-care is always a component of recovery. Often people with substance use disorders have not taken good care of themselves and sometimes need to relearn some of those skills. Mindfulness-based relapse prevention is also experiential, so it's not a process group per se where you sit around and talk about what happened in the last week or talk about your childhood trauma. It's really engaging in meditation, visualization, the practice of mindfulness, and then there's some processing of how that's going and people's present experience of doing that. It's very consistent with 12-step recovery principles. As many people know, the principles are grounded in Buddhist teachings, as is mindfulness, and so these are really compatible with 12-step recovery principles. And it's also compassionate and kind, which is always a bonus, teaching people how to be kind to themselves, and that inevitably helps people be kinder to others. Some of the misconceptions are that mindfulness is talking about your problems and stress, which it's really not. It's talking about how to be mindful and some of the struggles that we all have with that. Or that another misconception is that it's thinking about nothing. So I'm not very good at thinking about nothing. I can't shut off my mind. While that may be something that occurs, that's not necessarily the goal of mindfulness. The goal of mindfulness, again, is really about awareness in the present moment. And the other thing that's important, and some of our participants in this study have struggled with, is it's really not easy. It really takes tremendous practice. Ideally daily practice, and it's not passive. It is an active practice that people hopefully integrate into their everyday life.
So a little bit about our effectiveness study, and our study is an effectiveness study because it is real-world naturalistic setting, and that is one of the research questions that we had, is can mindfulness-based relapse prevention be incorporated into an outpatient setting where people come and go, where previously it has been people come in and go through the process lockstep for 8 weeks. So we're looking at this, can we see some similar results by utilizing an outpatient setting, which happens in a clinic in normal ways where people come and go at any time. Participants are recruited from our comprehensive opioid addiction treatment program at West Virginia University who are at least 90 days substance-free. And the reason why we're looking at 90 days substance-free is our initial experimental recruitment was with people who were just coming into the clinic and they were just not stable. And so we purposely are recruiting people that are a little bit more stable at this time and are more receptive to the idea of engaging in mindfulness. We're using a quasi-experimental design where people self-select into the mindfulness group or comparison groups, and we'll call that a treatment as usual or a TAU and MBRP respectively from here on forward. In the mindfulness group, participants attend a bi-weekly 60-minute session for 24 weeks, so every other week for 1 hour, led by our licensed therapist who we initially credited as Laurel Falkenberry. We're all part of the protocol, the IRB-approved protocol. Measures that we will discuss here this morning are administered at baseline, 12 weeks, 24 weeks, and 36 weeks post-intervention. The comparison group also continue with treatment in traditional cognitive behavioral therapy. As our mindfulness group, similar sessions, 60 minutes for also 24 weeks, led by a licensed therapist. So they just continue as they are. They also received the same measures at baseline, 12 weeks, 24 weeks, and 36 weeks post-intervention. Some of the outcomes that we're tracking are retention rates. We're interested in understanding if folks who are in our intervention group, if we retain them at a higher rate than we see with treatment as usual. We are interested in understanding if relapse on any prohibited substance, including alcohol, occurs less in our mindfulness-based relapse prevention group. We are also tracking time to relapse, and several self-report measures that we also have include craving, anxiety, depression levels, and mindfulness. Our measures of craving are a modified version of the desire for drugs questionnaire, where we have modified that questionnaire to expand it beyond opioids to include alcohol. We are using the overall anxiety severity and impairment scale for our measure of anxiety, and that is a clinically based instrument. And for our measure of depression, we're using the overall depression severity impairment scale. And for our measure of mindfulness, it's the 5-facet mindfulness scale. That's a 39-item questionnaire. Our overall hypothesis is participants in the mindfulness-based relapse prevention group will demonstrate increased retention rates in mindfulness and decreased relapse rates, craving, anxiety, and depression. Some of our preliminary results to date, because we are an ongoing study, we will continue to recruit through December 31st this year, and our project will end July 31st, 2019, so these are subject to change. Currently, we have 47 people that have been recruited into the intervention, which approximates to about 21 in our mindfulness group and 26 in the comparison group. Retention rates, or relapse rates, are lower in the mindfulness group at 22% with about 2 relapses. In our comparison group, 43% with 6 relapses. Importantly, for everyone to understand is that all relapses were on substances other than opioids. We think that is a very strong finding. Retention rates, mindfulness, about 29%, 6 people have been dismissed. In comparison group, about 23%, 6 people have been dismissed. So dismissal from the clinic results in from patient noncompliance or need for a right level of care. Turning to some of the self-report measures, we performed a mixed model analysis of variance to ascertain the significance of the MBRP intervention on changes in craving, anxiety, depression, and mindfulness between our two groups. In these analyses, we had 23 people who had at least 24-week data. So again, we don't have everybody that has completed all measures at this point. So that approximates into about 14 individuals in the treatment as usual group, 9 in our intervention mindfulness-based relapse prevention group. Analyses suggest significant reductions were observed in the mindfulness-based relapse prevention group and reported craving, anxiety, and depression compared to those in treatment as usual at this point. And I will say that on our anxiety and depression measures, where I don't have these data here for you today, however, the clinical instruments, if somebody receives a score of 8 or higher on either of anxiety or depression measures, that is a measure of clinical depression and or anxiety. And we are reducing participants in the mindfulness-based relapse prevention group to below clinical levels in these analyses, which is a significant finding. Interestingly, at this point in time, we have observed no changes in our mindfulness group, our reported mindfulness between our two groups. Our hypothesis is that as people participated in the intervention, that they would report greater mindfulness over time. However, we are not seeing that at this point in time. Again, it's early, preliminary, and subject to change. So some of the things that we're thinking about at this point, rates of substance use disorder and overdose in West Virginia are among the highest in the nation. Medication-assisted treatment is an evidence-based treatment for substance use disorder, but for individuals with co-occurring disorders, sometimes treatment alone is not sufficient. We have a very high number of participants with co-occurring disorders, as Ms. Lander indicated earlier. Preliminary study results suggest mindfulness-based relapse prevention can be successfully incorporated as a potential outpatient therapy for the treatment of opioid use disorder with medication-assisted treatment, in our case with buprenorphine. This has not been explored previously, and we feel very good about this, that this is a possible option for treatment for folks to give them a choice between traditional cognitive behavioral therapy or mindfulness. Finally, integrating and adapting evidence-based treatments into medication-assisted treatment has the potential to improve outcomes and decrease rates of relapse and overdose, especially those with co-occurring disorders. Thank you for your time. We've enjoyed providing this webcast and
And hope it was helpful.
hope it was helpful.